Good morning, everyone. We're going to start right on time today because we have a special presentation before Grand Round just for a few minutes. I want to introduce Mr. Clive Higgins, who's the Chief Operating Officer of Integrative, who's the company that has made our wonderful maps, and he is going to tell us about our new clinical map that we are launching officially today. I gave you a sneak preview last time, but so.
Hi there, good morning. Thanks for having me here. Just for a little bit of context, can you hear me okay? Yeah, okay. So a couple of years ago, we started working with Elaine and team on a research map, which you can see here. It's on the Osher website. And the objective for this was to connect researchers together based on not only institutional affiliation, but also on authorship and co-authorship across institutions. So the network map represents kind of three things. There are different institutions that you can click on. There are different modalities or treatments that you can drill down on, and you can see if you're interested in people who have expertise in acupuncture and in meditation, then they are, colored in two colors. The individual kind of people here are actual kind of real people, and when you click on them, not only does it tell you their affiliation, but it also then enables you to pull their record from the Harvard Catalyst database, their Harvard Catalyst profile, and also if they have authorship or co-authorship, you can click on the individual publications, and this will pull the individual publication in from PubMed. So that was really an attempt to connect the research community based on collaboration, and what we've now been able to do is extend this concept to a clinical network map. So it looks a little bit similar. There are some slight differences which I can go through. But if essentially you have institutions, you have also in addition on this map, you have within those institutions sub-institutions or centers or clinics. At Children's Hospital you have 4 sub-institutions here: Child Life Program, BC Medical Acupuncture Service, etc. And then within each of those institutions there will be individuals connected, and so you can look for clinicians either affiliated with institutions or again by modality here. If you are just interested, for example, in clinicians involved in the world of acupuncture, you can simply click on the side here. If it gets a little complicated to view, you can kind of pull these things around and make it a little bit simpler to view. And then, these individual people are identified within the map. Okay, so it gives you an ability to find clinicians not just based on institutional affiliation, but also based on their modality and treatment that they're involved in. The map currently represents somewhere in the region of about 100 clinicians, which is much less than it should be, and therefore we need to build that map out. And so there's a button here for clinicians who feel they are not represented on the map to register, and that simply pulls up this map registration form, which is pretty self-explanatory. It's important that the information on the map is is accurate, so we have to curate that information. So we ask for things like your name, the institution you're affiliated, sub-institution, email address, etc. And then here on the services that you would like to have listed, you can simply click them and add them on or maybe take them off based on based on your personal preference, and you can put in your expertise here as well, education, and any certifications, and simply hit that submit button. That information will then be curated by Elaine and team, and it will be represented on the map as soon as that curation takes place. So that's basically the call to action, as they say today. Please help us build out the map. We believe eventually this will be 2 or 3 times the size in terms of the number of people represented. So help us help you. Thank you.
Thank you so much, Clive. So you all, if you had not picked up an index card on your way in, you should do so on your way out, and it has the URL for getting on the map. So these little index cards that are right there on the desk. And so without further ado, I'd like to introduce Dr. Don Levy, who's the medical director of the Osher Clinical Center, who will run the presentation.
Oops. Okay, I'm already lost. How do I advance the slides? I'm here, I'm the bookend. I'm going to introduce and close the program. That's if I can get started.
I think it's down here. Oh. Here.
Where's that?
There.
Oh, so just click? Okay. Oh, I want to go back one. Is there a way to go back one? I know, but I can't use the board here. Can I make that work?
This mouse is terrible.
Well, my job today is to just place our talk in the context of integrative medicine.
Is that good?
Yep, and then what do I do? Can I use this?
I think so. Yeah.
Great.
So just use this.
Okay, you've already seen the first 2 slides. Excuse me? Oh, yeah, I will. I'll start by just placing this in the context of integrative medicine very quickly, 3 minutes, and introduce our speakers today. I think it's important to have an idea of what we mean by integrative medicine. And in our clinic, we've come to settle on this idea that it's simply an attitude of mind. It's a change of our attitude of mind and how we look at medicine. And there are 2 big components. One is we think the first medicine, the first intervention, the first treatment should be TLC, which is a therapeutic lifestyle change. Those are the most profound and powerful, and they can apply to just about any part of medicine. The other principle that's a little bit different is a belief in the innate ability of the body to heal, which to many is old-fashioned and no longer relevant. It's 19th century. It's too voodoo, and yet we believe it's powerfully important. Oh. This is a quote from a historian of medicine who has no particular interest in alternative or integrative medicine, but just writes about medicine in general. And I think he makes a fabulous couple of points. One is that Western medicine is one approach to healing among many. And the biggest observation he can make is that in large measure we've broken with this traditional wisdom of the body. And then instead of saying that's terrible or that's great, he says therein lies our strengths and our weaknesses. And I think that's important because when you break with this innate ability to heal, the body becomes a very fabulous machine. And now we have a bunch of parts and we need mechanics to fix it. And if it's amazing what we've done in Western medicine. You can break just about anything. In fact, at this hospital, we've transplanted a lot of things, from faces to just recently a penis. So broken part, fix it. That's a fabulous part of Western medicine. But it raises the question, would you like your clinician, your doctor, your dietitian to be more like a gardener or a mechanic? And I would say both, but I think we want to think about that, because the mechanic fixes the broken part, which is fabulous if you just have a broken part. But when you're connected to the whole being, it may not be enough. You may need gardening. I'm not a very good gardener, but I know there's some things you got to pay attention to, like the whole plant and the soil and nutrition and sunlight. You got to respect the flow of nature. Our goal really is to make the plant more resilient. And so to us, good health and good gardening is what integrative medicine is all about. Just like gardeners, we're going to pay attention to nutrition, which is today's topic. And if we were to summarize the functional medicine approach to nutrition, it would be increase the nutrients, get rid of the toxins, and put everything in balance. I just summarized the whole field. We're also interested in gut microbes, which is now becoming a hot topic for everyone in the gardening phase of medicine, and all these other things listed. They're so essential to me for healing, and this is what we do. So to introduce today's speakers, we're going to do gardening, and we're going to talk about nutrition. And we have two people speaking. Unfortunately, our patient couldn't make it, who just didn't want to be seen. But we do have even pictures of the food he eats that Caitlin managed to get. Caitlin Hosmer-Kirby is a senior nutritionist for many, many years here at the Brigham and has been at the Osher Clinic for years. And Kathy McManus is the director of the Department of Nutrition here and has worked for many, many years, many, many more years here at the Brigham and has worked with us at the Osher Clinic. Between them, they'll start to talk to you not just about the latest diet or something new or special, but how we get people to actually change. You don't just give a therapeutic lifestyle change like a pill. It has to be administered by people who know how to help a person take it, look at it, and then somehow metabolize it. So we'll start with Caitlin.
Thank you, Dawn. Good morning. Today, we hope to give you a sense of what it's like to take somebody through the process of lifestyle change. And as Dawn mentioned, our patient couldn't be with us, but this is somebody that we all see very commonly, has many traits that we are going to emphasize as common in our work so we can take advantage of the lessons. KB is, oops, sorry. Okay, KB is our patient today. He is a 57-year-old male, very commonly has neglected his health for many years. He is bright and warm and engaging, but he enters the appointment with some trepidation, some hesitation, saying, I don't like to be told what to do. He's a little skeptical about whether this is going to be valuable for him or not, but he doesn't like the situation that he's in. He says, my belly hangs over and I'm overweight and I would like to not be on my blood pressure medications anymore. He's an accountant, excuse me, he owns his own business. He has 2 college-age children. He's married to someone who had a gastric sleeve operation. And from his perspective, she doesn't eat very much, but she eats bad things. She keeps bringing things into the house that used to be what she ate before, that he would rather not have in the house. But as long as she keeps her weight stable, that's fine with her. So that's a factor for him. And excuse me, he eats lightly during the day, so because he's been trying to lose weight. He comes home after a stressful day and has 3 to 4 glasses of red wine at night, which he says makes portion control difficult for him. And he has been trying over the past month to make some changes. So he's eating more vegetables than he ever has in his life, according to him. And he has a Fitbit, and he's walking 7,000 to 10,000 miles a day. 7,000 to 10,000 steps. These are his diagnoses. He's on 2 blood pressure lowering medications and multiple supplements for various reasons. And a couple of points to mention about his clinical parameters. So these were taken 2 weeks after he saw me. Just want to note that his blood pressure is 159 over 105, and this is while on his medications, and his BMI is 35. His triglycerides that were taken a couple of months before I saw him were 220. So in summary, he is a middle-aged man who's not paid attention to his health. He does show up for his nutrition appointments, so he's interested enough to come, but he does express some trepidation and some skepticism. He has multiple chronic diseases. He has professional success in a stressful life and looks to food and drink for a lot of the pleasure in his life. And this is what we have to work with. So Kathy McManus is going to talk about the theory of what we would talk about and how we would talk about it with the patient, and then I'm going to come back and talk about my specific work with him.
Thanks, Caitlin. So, as clinicians, our job is to ensure best practice from both the science and the art of healthy eating. Beginning with the science, KB has hypertension, and he has a number of cardiovascular risk factors. So we thought that looking at the DASH diet approaches to stop hypertension, was appropriate for him. As many of you may know, this was an 11-week outpatient feeding study led by Dr. Larry Apple and Dr. Frank Sachs at Harvard. DASH had 66% minority participants who had an entry, were borderline hypertensives. The participants' intake of sodium was the same across the diet interventions at 3,000 milligrams per day, and their weight was kept constant. So what DASH looked at was different dietary patterns, the control diet, or similar to what most Americans were eating, the fruit and vegetable diet, which was the diet that just added some additional fruits and vegetables to the control diet, and then what was originally called the combination diet eventually turned into the DASH diet, high in fruits, vegetables, low-fat dairy products. So what this diet had was an emphasis on fruits, vegetables, whole grains, and low-fat dairy, which actually translated to a diet high in potassium, magnesium, calcium, and fiber. So what did it find? Well, the DASH diet showed a significant decrease in systolic and diastolic blood pressure compared to both the fruit and vegetable and the control diet. And it actually was sustained throughout the 8 weeks. The decrease in blood pressure began within 2 weeks of starting the diet. Another key finding is that the pressures were reduced in subjects who had high normal blood pressures, suggesting that this may actually be an effective approach to prevent hypertension. The investigators then wanted to decide whether this could be further enhanced by reducing sodium. So they examined 3 different sodium levels: of low sodium, 1,500 milligrams, intermediate, 2,400 milligrams, and a high sodium, about 3,300 milligrams. They randomized participants into a usual U.S. diet or the DASH diet with these 3 different sodium levels. Again, it was a feeding trial, all food provided, and weight was kept constant. Results showed that there was a large additive reduction in blood pressure with the DASH and low sodium diet combination compared to the usual higher sodium plan. They saw a 15 millimeter decrease in systolic blood pressure. This lowering was actually greater than single antihypertensive therapy. Since KB has a number of cardiovascular risk factors, he may also benefit from results that was found in the OmniHeart trial. This study was also a randomized feeding trial that substituted some of the healthy carbohydrate in a DASH type diet with either lean protein, half of which was vegetable protein, or unsaturated fat, mostly additional monounsaturated fat, such as olive oil and nuts. Results showed a further lowering in systolic blood pressure, LDL cholesterol, and triglycerides, from which KB had an elevated level of 220. As evidenced by DASH and Omni, one of the most powerful and positive messages we can send to our patients is that by improving the quality of our diet, our patients can improve their health, even if they don't lose weight. Now let's turn to the art of changing behavior, or where the rubber hits the road. One simple but brilliant quote by Michael Pollan is, "Eat food, not too much, mostly plants." Simple, right? But how can we help make that change? Although patients appreciate, I think, our support and expertise, one recently felt that she wanted to cover all the bases and added prayer. Dear God, my resolution for 2016 is a big fat bank account and a slim body. Please don't get the two mixed up like you did last year. It's critical for us as practitioners to have the knowledge and science behind us to be credible in counseling patients. However, telling someone what to do does not ensure that they will do it. We need to move beyond informing and move toward inspiring. As we know, most of the patients we counsel have deeply entrenched habits. As Mark Twain so wisely stated, habit is habit, and not to be flung out the window, but coaxed down the stairs, one step at a time. When we counsel patients to support a change in behavior, we're often asking our patients to give up things that are inherently pleasurable and replace them with things that are not. How we deliver the message is the key to convincing our patients to actively make the change. As practitioners, it's very tempting to just tell them what to do. All with the best intentions, but obviously not the best results. I'd like now to briefly discuss 2 skills that can assist us in helping patients change their behavior: managing patients' expectations and motivational interviewing. The first principle in managing patients' expectations around weight is to help establish a realistic goal and aim for modest weight loss. As we know from the diabetes prevention program, a 5 to 10% loss of initial body weight is medically significant. It can reduce blood pressure, blood glucose, and LDL cholesterol. The patient needs to start to build some confidence that they can actually be successful at losing weight. Setting too high a goal will prevent them from realizing positive small steps. Another way to support managing patients' expectations is to help them recognize that obesity is a chronic disease like diabetes, hypertension, and hyperlipidemia. Weight management needs attention and treatment over the lifespan. It's not a quick fix that goes away once weight loss occurs. The third important strategy is to help manage patients' expectations, is to emphasize that long-term weight control is doable, focusing on the big picture and really helping them support the idea that previous attempts and diets were just that, diets, not a healthy eating lifestyle. There aren't any absolute do's and don'ts. The goal is attaining a lifelong healthy weight. Finally, helping to communicate to the patient that you recognize how difficult it is to lose weight and keep it off. Letting them know that you understand the complexities of weight management and that it's a continuous work in progress. Reiterating that you are there to support them through this long-term effort can be very powerful. On the positive side, data shows that participants in the National Weight Control Registry weight loss can be sustained over time. In this study, there were 748 participants throughout the U.S. The criteria to enter the study was they had to lose a minimum of 30 pounds and keep it off for a minimum of 1 year. Results from this initial paper showed that these participants had an average weight loss of 65 pounds and kept it off for an average of 5.7 years. Pretty successful. So, what were they doing? No surprise, number 1 was physical activity. These individuals were expending about 400 calories per day. So it could be an hour of a 15 mile per hour walk, so about 4 miles a day. No one diet, but overall healthy eating, self-monitoring, daily weighing, sustaining behavior changes, and support system. So for those folks who don't believe that they can keep weight off, we can help support them and say, yes, you can. Here are some of the principles that will help support that. The second skill to help supporting patients changing their behavior is motivational interviewing. MI is an evidence-based style of healthy behavior change consultation, and there certainly is a growing body of evidence showing that it can be effective in weight management and lifestyle management. The spirit of MI is shown in the 3 E's: elicit, asking questions. What can I do for you? How can I help you? This strategy helps our patients set the agenda. Empathy demonstrates a sincere interest. It lets the patient know that you're open to understanding both sides of the change status quo debate. It reinforces that you're not here to judge, but rather to help them in their process of change. It's important to let the patient know that you understand how they feel and what their issues are around this behavior change. Empowering begins with respect. It avoids the traditional healthcare consultation of top-down, with a power differential in favor of the medical expert. It allows for sharing of that power in the relationship. The message to the patient is, you have everything you need and we'll find it together. One key element of MI is empathetic listening, which involves building rapport. To do this, it's important to meet patients where they are, listen with presence, without interruption, and with curiosity. Rather than a practitioner knows best, relationship MI uses the concept of dual expertise. Practitioner being the medical expert, the patient provides expertise in self-change. Only the patient has the depth of understanding as to what might work and what might not, given their lifestyle and individual priorities. Focus on the patient's positive experiences. Can you tell me about success in the past? What have you tried that you found helpful? These questions and responses help mobilize the patient's own resources and allow for more natural change. Another important component in building rapport is to identify connections, asking questions such as, what matters to you and why? Why does it matter to you? Listening to the answers and identifying the connections between health and what's important to the patient can be very powerful. If the patient can articulate this link, they will more likely follow through on the behavior change. We must harness the motivation of our patients if we're going to help them change daily habits for the better. MI has a lot to do with restraint. What you don't say goes a long way. MI is a combination of collaborative instruction, purposeful listening, and guiding. Guiding means to encourage, support, awake, promote autonomy, elicit solutions, and collaborate. I can help you solve this for yourself. Asking permission is another important technique in MI. Would you mind if I weighed you? Can I share my thoughts about your plan? These statements put the patient more in control. It's a shared power. Rolling with resistance is another key skill in MI. Inviting it in, listening to it, and empathizing with the patient can help move things forward. One strategy around resistance is giving permission to stay the same. What do you like about being overweight? What would you miss if you make the changes in what you're eating? More often than not, having been heard, some patients will be able to be more open to what you have to say. Some general words of advice around language: avoid the I think, you should, choose more neutral words folks have found, others have benefited from, or conditional words such as might consider. Another technique in MI is using the importance scale, asking how important is it for you to change? In other words, why? Patients rate the importance of changing a behavior on a scale of 0 to 10. If the patient rates the importance as a 5, I would ask, why are you a 5 and not a 2? This invites some discussion around the change process, and again, can connect the patient to the purpose and meaning of why they want to make a change. What would it take to raise your score to an 8? Asking why it's important that they change is paramount to the process. MI, unlike standard interviews, is aimed at getting the patient to consider the gap between where they are currently and their imagined state of health. If the patient can't access answers to the why question, it's doubtful that they'll be able to succeed in maintaining their goal over the long term. Along with importance is confidence. If you did decide to change, how confident are you that you could do it? Again, asking the patient where they sit on this scale. Data shows that unless a patient reports a confidence level of at least a 7, they'll have a very difficult time making the change. This exercise can be a perfect segue to help patients build their confidence. The practitioner can offer a menu of options. Where would you like to begin? What barriers do you see? MI is truly a partnership and a collaboration, not a top-down instruction. It's their decision, fueled by their intention and level of motivation and confidence, that will produce successful change. When you start to hear change talk, offer options to help increase motivation, confidence, and commitment. Making small incremental changes can lay the foundation for larger long-term success. Even very small steps are important to the process. Understanding and supporting the why the patient wants to change and helping with the hows can set the patient up for success. And now I'd like to bring Caitlin back up to talk a little bit about KB's progress.
Okay. I'm going to guess that we are all parents or children or significant others or clinicians of people who don't like being told what to do. We are people who don't like being told what to do. And helping to support people in making change when they don't like being told what to do is difficult. How many people in the room, just out of curiosity, have ever tried to make behavior changes around health themselves or support somebody they care about in making changes? I know I have, and it's really, really hard. And theory is just the beginning. Whoops, that was an accident. Okay, so as Kathy mentioned, the importance of making actionable goals, small pieces that people can attach to, is very, very important. One size does not fit everybody. Everybody except for certain acute situations or high-performance science junkies tweaking their metabolism, for the most part, can benefit from the theory of the DASH diet and the OmniHeart trial and other studies that Kathy mentioned really do apply to many, many of our patients. So that's very, very applicable. Our patient comes in saying big things like, I don't want my belly to hang over, and I don't want to use blood pressure medications anymore. I want to lose 50 pounds. These are very big things, but they need to be something that we listen to and help get into these smaller pieces so he can actually make some changes. So what's required when someone comes and sits with us is to move them into a position where they're taking old behaviors and replacing them with new behaviors. A shift needs to happen in the course of that conversation. And one of the ways that that happens is creating a relationship with the person. And motivational interviewing is one of the ways to actually be able to meet the patient where they are and to be able to establish a relationship. Without that relationship, often the shift just doesn't happen. So ambivalence is a very common scenario. I really don't like where I am. I don't like my current situation, but I don't really like the idea of changing. I like what I'm doing. They have clear goals, but the desire to change is not really clear. I want to feel full, but I don't want to eat the things I'm eating. I want to lose weight. I don't really like the idea of exercise. I really like having a loaf of bread with butter a couple times a week at night. And the idea that change requires doing something different, while it seems really simple, is something that people are often ambivalent about when they come and sit with us. So ironically, as Kathy mentioned, it's sitting with that ambivalence with the patient to say, okay, what if you don't make changes? What if you keep eating the way you're eating? You said you really wanted to not take blood pressure medications and your blood pressure is high, but what if you keep eating the way you're eating? To give them some room around that ambivalence to realize that if they don't change what they're doing, then things won't change. And one of my colleagues, who's not here today, but he asks this brilliant question. He makes this brilliant statement to people that if they don't make changes that they need to make in their health behaviors, then today is probably the healthiest day of the rest of their life. So that may be something that is helpful to motivate people as well. But giving people that space to not be sure about it helps actually move them forward. That's ironic, but it's true. So I'm not usually going to be the person to point out that what they're saying doesn't make sense, that they want all these changes, but they don't want to do anything about these changes. It's much more helpful if they can reflect on that and realize that is where they are, and it's more powerful if that realization comes from the person who's sitting with me. So helping them consider that distance between where they are and where they would like to be, ideally, For example, KB, who doesn't want to take the medications and doesn't like the feel of his belly. What would it take to get there? What do you think it would take to get there? What might you do differently? I always ask people what they think they could do differently, because some things come out in the course of a conversation, take a long time to come out in the course of the conversation, that if you ask them that in the beginning, they may admit to, well, I could do less of this or more of that. So how do we bridge that gap? Our role is really to guide them to go from, here's what I'm doing now, here's what I might be able to do to make these changes that I want, and that comes from meeting the patient where they are, as Kathy mentioned. So we get a lot of clues from these conversations when we're asking them questions and giving them space to talk about themselves. So he said, I'm kind of skeptical whether this is going to be helpful for me. I don't really know what to expect. So I can tell him about the session. We're going to talk in a lot of detail about what you're eating and your health and your eating behaviors. And you're going to leave here with a couple of suggestions that we come up with together for you to work on over the next couple of weeks, 3 to 4 weeks. And then we'll come back and we'll take a look at how you've done and what could be different and what questions you have. He said, I'm slowed down by my weight, which is a really important thing to hold on to, because when he's saying, I kind of like eating at night with my wife, but then I don't like being slowed down by my weight. He needs to remember these things when he realizes that the feeling of deprivation may come up for him when he knows what he needs to do. It looks like he's having a problem in the evening. His evenings are tough. He's drinking 3 to 4 glasses of red wine. That makes portion control difficult. I'm having a hard time. I take stress out on food. From my perspective, I see that he is trying to lose weight, so he's under-eating early in the day. And he comes home hungry, and we know from the data about willpower that it's a finite resource, that over the course of the day, as we make decisions, our willpower decreases. So the nighttime and being vulnerable at night is an absolute setup for having a problem with eating. So he comes home stressed, he has no willpower left, he has 3 to 4 glasses of wine, and he's really hungry. So this is clearly an area that's problematic. But when we are having the conversation, I can ask the questions and he can realize that this is something that's very related. These are steps that are happening, and he's setting himself up for this overeating in the evening, which, as he says to me, is this is where I eat the things that I really don't think I should be eating. So even though we can get a lot of clues from these conversations, we also can have resistance at the same time. We hear resistance. So I do want to lose weight, but I don't want to give up these things. My wife brings home these foods. I wouldn't eat them if they weren't there, but I like to have food with her, and I have a lot of stress. So this is real life. There is stress, and there's food in the house that shouldn't be eaten, and these are issues that are difficult to manage. So it's really clear. You start to see that handing somebody a diet or saying, well, just do this. Right? Why don't you just do that? Just stop doing that at night. Just, don't eat those foods when you're hungry and you've had too much wine. Try not to have that bread and those desserts. He said, 2 nights a week, I probably eat a whole loaf of bread with butter. I'll have dessert at least 1 night a week. Sometimes my wife has hamburgers and pizza that I wouldn't normally eat myself, but it's there, and this happens at night. Okay, so many people think that they want to have a diet handed to them, and that's what they come to the appointment for. They're not really clear that we're going to actually have to talk about what they're doing and what they may need to do to change, which will actually give them what they want in the long term. So it is true that most people make small incremental changes, and making small incremental changes may make maintenance easier or keeping things up for the long term. But some people are all or nothing and do like to take the deep dive and say, I'm going to get the pain all over with in the beginning and make all of the changes and see those results more quickly. And that is very powerful also. There's nothing really more powerful and more motivating than seeing change. So you may have somebody in either of those camps, and part of the conversation is to get a sense of what kind of person they are and what may make the most sense for them. Another piece is that the incremental changes and then the results that people see is an opportunity for them to reflect on the connection between changes and the results that they want. So if they're just making small changes and they're only seeing small results, and they don't like that, they'd like to see bigger results, then maybe if they make more changes, then they will get bigger results, or they make those changes more often, more regularly. So we have this detailed, long conversation, and there's a long list of changes that may be beneficial for him based on his clinical situation and the research and his behaviors, but that's too much. It's too much to hand somebody that much information and expect those changes to happen. So together, we look at what are the low-hanging fruit, what are the things that make the most sense, and that may be those are the easiest changes for him to make. They're the issues that happen most frequently, so if he changes those, he'll get the biggest results. And just what appeals to him to be the next steps. So we come up with 3, and as you can see, they're all related. So if he has more robust meals earlier in the day, he comes home less hungry. His overeating these processed carbohydrates and sweets goes down. If he also has 1 to 2 drinks of red wine instead of 3 to 4, then he's less susceptible with his problem that he perceived as making him more hungry and the issues with portion control. So again, it takes a lot to get to this. Some very few things that are relevant to this person, and it's not what many people think they're coming in for, which is here's what you need to do, just the list. Here's the information. And people can look up a lot of things these days, and the information is not what makes the difference. So he goes away for between 3 and 4 weeks, and he comes back with some of his record keeping, his photographs that he's taken, and so he shows me eggs with lots of vegetables in them. He puts some meat with lots of vegetables in it. He thinks of creative ways to bring vegetables to work. He loves working with the crock pot where he throws a little bit of meat and lots of vegetables in, and he can eat that for lunch, and he can eat that for breakfast if he wants. A lot of vegetables and a lot of creative thinking, and he's feeling good about it, and it's fun to see the pictures. He also says, I'm feeling better. I want to make sure I say that. He said, I feel like I'm shrinking. It's working for me to front load the food early in the day, so I'm not eating so many of the bad things at night. He's also working with some of my Osher colleagues, Dr. Kowalski in chiropractic and Tom Jacobson in massage therapy, and he's just feeling better in his body. He says, I actually tried to go for a little bit of a jog where I never would have done that before. He does feel he's indulging in a little bit of self-flagellation because he has not lost weight. Okay, so it's only been 3 to 4 weeks. And so, it's only been 3 to 4 weeks. So I wouldn't necessarily expect weight loss, but that's definitely something that he's focused on. So in the follow-up, we get lots of positive reinforcement for the changes that he's made, which in his mind, because he's focused on weight loss, may not be so important, but they really are. We discussed the 80-20 rule, that this is not about being perfect all the time. This is about what you're going to be doing most of the time, and hopefully most of the time forever, and that's what's going to make the difference over the long term. This is a shorter appointment where we review what's happened and we reflect on what's happened, and we go back to the initial issues that we came up with, that list, because it takes multiple appointments to go back to that list. It's not, here's the list for the first session, and the second session we have a whole new list, because it takes a while to get those things down. So we go back to those 3 issues, and we talk about what's worked and what hasn't worked. Maybe he could do it a little bit more often if he was looking for weight loss a little more quickly. Maybe his portion sizes could be smaller. Even if you're eating well, maybe he's eating a lot, but he's trying to emphasize the eating behaviors and the quality and managing what has been off before, and he's looking pretty good. And again, this is an opportunity to discuss the disconnect between, maybe I could have done that a little more, and then I might have seen more of what I wanted to see. Okay. Whoops. Well, sorry. Some other results. So some of these you saw before. The blood pressure that was taken 2 weeks after that I saw him was 159/105. 4 months later, on the same medication, his blood pressure is 132/81. His weight is the same. The triglycerides that were taken a couple of months before I saw him at 220, 3 to 4 weeks after I saw him were 163. So this is pretty good, but these actually don't reflect something that I would think is maybe even more important, which is his change in attitude, that he has experienced that he's actually in control. While he came in saying, I don't want you to tell me what to do, and I don't like somebody else being in control, he now has experienced the idea that to make these changes, he has to change his behaviors, and he can change his behaviors to get to where he wants, and nobody's telling him what to do. There's nothing more powerful and more motivating than feeling better, and this he has expressed within this relatively short period of time, even though, you know, the numbers are one piece of it, and they're not perfect, but things take time. So there's clearly room for improvement, and I would have loved more time with him and for him to follow up more closely. As I mentioned initially, he's an accountant, so we're now getting into the early months of the year, and it's busy, but he, as you can see, even months later, has made some good progress. And we picked him on purpose not to be the perfect patient, by the way. But this is real progress. Okay, so I'd like to just emphasize a couple of things in takeaway. All of us, any clinician in any discipline, has the opportunity to make a real difference by emphasizing that lifestyle change makes a real difference. It really, really matters. We all have that ability, and it makes a huge difference when patients hear that from a clinician. They affirm it. I think a lot of patients actually feel it themselves, but until they hear it from someone else, sometimes they allow themselves not to believe that that's true. So any clinicians in the room have that opportunity, regardless of what the experience is with your patient, the reason that you're seeing the patient. I also want to emphasize, at this point at the end, I had a couple of other slides talking specifically about some of the foods to emphasize, but I took them out because of time. But I do want to say that there's a lot of research and energy and resources that go to looking at the perfect proportion of macronutrients for the ideal nutrition intervention. And by macronutrients, I mean carbohydrates and fat and protein. And as it turns out, there's not one size fits all, actually, is what it looks like, not surprisingly, because we're all different. But what we are not paying attention to is the micronutrients. And what I mean by micronutrients are the 30 to 40 vitamins and minerals, essential fatty acids, and amino acids that are required to run the chemical reactions in our bodies every day, in addition to many trace substances that we don't have RDAs for at all, like the hundreds of phytonutrients, things like carotenoids, and probably hundreds of others we haven't yet discovered. These are things that don't change in our need from person to person. The macronutrient proportion that's ideal probably does change. The need for the micronutrients to run those chemical reactions in our body does not change. And I would love to see the conversation focus more about the adequacy of the micronutrients, because it's clear that there's no one magic answer from the other perspective. So that's what I would say in closing. Thank you very much.
And my job is to wrap it up. Again, put it in the place of the big picture. You saw a standard patient, overweight, high blood pressure, high triglycerides. The same principles apply when you use therapeutic lifestyle changes. Again, it doesn't come in a capsule. So the word I would put, the space I would put this in the little epilogue, which I looked up, it's a short piece that wraps up the story, is the word epigenetics. Epigenetics, to me, is the most exciting part of medicine, and I think integrative medicine is focused right in it. It's the way that we can alter the hand we were dealt genetically. Some people think of them as chemical switches that can turn on and turn off the genes that we already have in our DNA. Here's an example. DNA is strings of just a 4-letter alphabet. There's guanine, and the yellow and the purple is cytosine and adenine and thymine, and it goes on and on and on. But in this case, on the cytosine, there's a methyl group, and methylization is one way you can turn on or turn off a gene. We're just learning about this. This is fascinating stuff, because turning on and turning off a gene, what are the switches? Well, look at what the switches are. Does this look familiar? This is what our kind of medicine is all about: diet, dietary supplements, exercise, stress management, taking a look at your sleep, other health habits, and then there's a huge huge movement nowadays to look at our environment, the toxins, the things that trigger us, nutrients, lack of nutrients. Those are epigenetic switches. So we're back to where we were before, good health and good gardening. Integrative medicine is gardening, and I think we could call ourselves applied epigeneticists, but that sounds dumb, so we won't do that. Also, no one will know what we're doing. I'll give you 2 examples to close. Since, back here we've done a little bit about diet and dietary supplements, exercise and toxins. Okay, well, they just separated identical twins, and the end of our DNA strands come just like they've been compared to a shoelace. And every time our cells divide, the shoelace, that little thing at the, what do you call that thing at the tip of the shoelace? But it gets a little shorter and shorter and shorter, and finally, when it runs out, that cell probably dies or gets senescent. And the people who are more active change the length of their telomeres at the end of their chromosomes. Pretty amazing. It's an epigenetic change. And the last one, which I'll close with, is I call this an epigenetic intervention. The mice, the little mouse, it's browner, darker, is what the normal mouse looks like in this strain. And about 10% of the time they come out plump, like the golden-haired one. They are prone to be obese, get cancer, and diabetes. Now, they fed the healthy type mice bisphenol A, the stuff that's in those, it used to be in these bottles and is in our environment. They fed the mice directly, a lot of bisphenol A. And guess what happened? 20%, more than doubled, the mice came out like the one on the left. So then they wanted to see what the problem was, and I'll cut it short. The theory was we have to methylate a certain genetic part. So they fed the mice, who are now pregnant, another set of mice, folate and genistein. And when they did this experiment, it turned out that it reverted back. They were able to reverse this toxin exposure with folate and genistein, and it came out about the exact same ratio as normal. So this is the future, I think. Epigenetics from therapeutic lifestyle changes, dietary supplements, ways to tweak the way we live. And I think the final say would be epigenetics explains how TLC, not just DNA, creates our destiny. So we'll stop there, and we have a few minutes for questions.
Well, first of all, that was really well done, well conceived and delivered. KB came in at a point where he was ready for change. As a clinician, I get people where they're ready, they should be changing. And how do you get them to that point where I'm ready to make changes in my life? And of course, nobody wants to be told that, like you said, anything about making change, or what do you mean I'm fat? Those type of things. So do you have any advice, at the level that people, maybe a year before he came to you, to move him along?
That's a good question, because even if people are resistant, when they come to me, they're actually there. So, sorry, did everybody hear the question? How to help move people along if they're not quite ready. I know that you like Prochaska's theory of readiness to change, the stages of readiness to change, and it's definitely true that not everybody's there. Sometimes asking them about their health, or if they have anything that they don't like about what's happening, or has anybody mentioned to them, it probably depends on why you're seeing them, because even when people are resistant, will just attach to the fact that they showed up, even if their arms are crossed and they're saying that they don't like, they're afraid of what they're supposed to hear, or they think that I'm going to take everything they like away from them. I think a lot of questions and listening is helpful, and maybe as you work with somebody, just ask questions. I wonder what Kathy has to say about that too. It's definitely difficult, but you have to tap into something for them.
Yeah, I agree with Caitlin. I think one of the questions that I would probably try to engage them around is barriers. Because I think that sometimes people feel as though it's just too difficult. There's just too many barriers in my life. I'm just I don't have the time, I don't have this, I don't have that. And trying to get them to kind of have a conversation around what they perceive as barriers, and then work through one or two of those to try to make it a little bit easier or more reasonable, that they think that, oh yeah, okay, maybe I could do that.
I have a question, but just a comment on the previous question. I think one of the things I find is often it's helpful to ask somebody the simple question of what bothers them about whatever they're talking about. If you can get them to talk about what's bothering them, it's a little closer to that kind of sweet spot of the self, the one you want to get involved in the conversation. Sometimes you get answers like, well, what do you mean what bothers me? Of course, it's sort of obvious, but until you get their answer to that, it's a little abstract. I also thought I wanted to sort of comment on where to reinforce this essential partner of the patient's self in the change process. I thought the motivational interviewing description was great. It's a lot like basic good psychotherapy, really. And but it's there was one comment about resolving ambivalence, and I think that could lead clinicians to be a little frustrated because I think ambivalence is a little bit like the famous psychologist Yogi Berra says, when you come to a fork in the road, take it. And that there is also an acceptance necessary, that ambivalence, people are going to hem and haw whether they're approaching end-of-life decisions or food or whatever. That's just, they're two sides. And I think allowing that to be voiced at almost every session that you have is important. And the last point I had was the when this KB came back for the second follow-up interview, it seems really important to ask him what he's learned. And I don't know if you did or not, but that in my field, in like this sort of psychotherapeutic mindfulness field, the phrase insight is 90% hindsight is really important. So what is the patient seeing in the rearview mirror after 2 or 3 months of change, and how can they, say it to you?
You mean what has he learned about his behaviors or about the situation, or
about the process from day one to the third month? What has he learned along this way?
I think he was surprised, and one of the things that he did say to me that I had to not laugh to was, he said, I don't know how it happened, but we started off with my not wanting you to tell me what to do, but now we're on the same wavelength. And I think it was the process of him feeling as though he was in control. It was like, he was really resistant to, you tell me what to do, I don't like that, but I'm in control, and I made these changes. But that's a great question to ask. Thank you.
Hi, I'm a naturopathic doctor, so this is my native language, and I thought you did a great job with the presentation. I really enjoyed it, and I hit the same sort of sticking point when I'm working with people, which is that weight can just be a really damning number to track. It doesn't necessarily reflect progress, and it's not necessarily very motivating for the patient. So I'm wondering if anybody has sort of figured out a way to track other whether it's a depression index or whether it's the, I think, awesome opportunity of Fitbit data to see is sleep improving or steps improving. Are there other markers that you're starting to implement in terms of keeping a patient motivated and moving forward where there's not a clear change in weight or blood pressure yet?
Yeah, I think there are a lot of other markers, just as you describe. And again, having it come from the patient as far as what are some of the other things that are of interest to you. What I try to emphasize is the quality of and the change of some of the foods that they've made. As you saw with KB, he was just showing pictures of vegetables. This was something new to him, and he was really psyched about. But you saw from the data, I mean, I think that's such a powerful message for us all as clinicians. You don't have to lose a pound, and you can improve your health. That's really, really powerful. And those numbers are real as far as making that happen. So I think kind of focusing in on the changes that they've made in the quality of their eating pattern is huge.
So thank you so much. We have to close now, but thank you so much to our presenters. Excellent presentation. And of course, we have our coffee hour afterwards. Please stay and share with each other. We can continue this discussion. I want to make sure to remind people that we are not having grand rounds next month. It's the 4th of July week, and so we are not having a July presentation. However, our next grand round is going to be Tuesday, August 3rd, and it's going to be on Reiki therapy and conventional medicine, integrative and comprehensive approach by the Zakim Center for Integrative Therapy. Should be very, very interesting. And also, please pick up, if you have not on your way in, pick up one of the index cards for the URL for the Osher clinical map and check it out. And if you're not, find yourself on the map. If you're a clinician, if you're not on the map, click on the register button and fill in, and we'll put you on the map. Okay? So thank you very much.